Hi, my name is Stephanie Lee, and I'm a second year orthodontic resident. My research topic is titled The Effects of Mouth Breathing in Children and Adolescents, and my PI is Dr. Cheever. When we think of negative dental childhood habits, we often think of habits such as thumb sucking, nail biting, or lip biting. But there is a physiological habit that can literally reshape a child's face and alter their long term health: mouth breathing. While it sounds simple, mouth breathing is a complex oral habit. It occurs when a child stops breathing exclusively through their nose and supplements with, or relies entirely on, the mouth. Clinically, we define this as a state where over 25 to 30% of air passes through the mouth for a duration of more than 6 months. The reported prevalence varies widely, ranging anywhere from 6% to 56% of children. But why does it matter? According to Moss's functional matrix theory, form follows function. The normal respiratory function is the engine behind the proper growth of craniofacial structures. So if normal function changes, the form follows, often with deleterious effects. The causes of mouth breathing are multifactorial, but the most common culprit is an upper airway obstruction, which can occur in the nasal cavity, nasopharynx, oropharynx, or the laryngopharynx. Obstruction in the nasal cavity most commonly occurs due to inflammation from allergic rhinitis. It can also occur due to morphological issues like a deviated septum or nasal polyps. Obstruction in the nasopharynx often occurs due to adenoid hypertrophy. The adenoids actively grow between the ages of 2 and 6 and decrease after 10. If they become pathologically hypertrophic, they don't atrophy as they should, significantly reducing the space for air. Obstruction of the oropharynx can occur due to tonsillar hypertrophy. Tonsils actively grow between 2 to 5 years old and usually disappear by 14 to 15. If they don't atrophy as normal, the space for air, again, is significantly reduced. Beyond physical blocks, we have habitual factors. Sometimes, even after the allergies are treated or the tonsils are removed, a child continues to breathe through their mouth out of habit. Lastly, anatomical factors like a short upper lip or lip incompetence can make it physically difficult for a child to keep their mouth closed. When a child breathes through their mouth, their tongue posture changes. Instead of resting against the palate, the tongue drops low and forward. This lack of internal support leads to a constricted V-shaped upper arch. The result is a cascade of dental and skeletal shifts. We frequently see posterior cross bites, anterior open bites, and increased overjet. While a class 2 with a retrognathic mandible is commonly observed, a class 3 appearance can also occur if tonsillar hypertrophy is present as a child positions their mandible forward to open the airway, as shown in Figure 1. Over time, this develops into what we call adenoid facies or long face syndrome. The skeletal markers are distinct: a downward and backward rotation of the mandible, a high arched Gothic palate, and an increased lower facial height. The consequences extend to general health. Inside the mouth, saliva is our natural protector. Mouth breathing evaporates that saliva, leading to dry mouth, which increases the risk for gingivitis, especially in the upper front teeth, and leads to higher levels of strep mutans, the primary bacteria behind cavities. Even more concerning is the link to sleep disordered breathing. Mouth breathing is a major red flag for obstructive sleep apnea. If a child isn't breathing well at night, they aren't sleeping well. This manifests as irritability, daytime sleepiness, and poor performance in school. Treatment must be multidisciplinary. We have to treat the cause, not just the symptom. If there's an obstruction, an adenotonsillectomy or allergy management is the first line of defense. There's been some discussion on utilizing rapid maxillary expansion, otherwise known as RME, which widens the maxilla and can increase nasal volume. However, research is still mixed on whether RME effectively reduces mouth breathing, and some suggest that RME is not justified in the treatment of mouth breathing in the absence of a maxillary transverse discrepancy. In functional or habitual mouth breathers, oral myofunctional therapy is a treatment option. OMT re-educates the muscles, strengthening the lips and tongue to re-establish a proper resting posture. Mouth taping as a treatment for mouth breathing has been popular on social media. There is some limited evidence that it can help reduce snoring and the apnea hypopnea index in some patients, specifically those with mild sleep apnea, but other claims such as improved immunity, skin, and digestion are not supported by research. For functional mouth breathers, a lip seal test using masking tape can be used at home to progressively train the child to breathe through their nose. Because dental professionals see children early and frequently, we have a unique window of opportunity to intervene and treat during their peak growth periods. By screening for mouth breathing, observing facial growth patterns, and checking for lip incompetence, we can intervene before long face syndrome becomes permanent. Thank you.